Thank you for joining us in today's new live session with the new timings, 12 p.m. instead of 2 p.m. Today's session will be on thyroid, the symptoms and what is a thyroid, but we will not go through the thyroid glands, where we will mainly focus on the thyroid management and the thyroid nodules management with the doctor. And today I would like to welcome Dr. Qudratullah Al-Asbih, Consultant General Surgeon and Surgical Oncologist at Medcare Hospitals in Dubai. Please, I would like to encourage you to share your questions and the doctor will be more than happy to answer them. Doctor, thank you so much for being with us here, and I'm sure you will be happy to answer our audience questions.
At your service, I appreciate the invitation. I'm very happy to be here. I wish all of our patients, family, and friends are safe and sound.
Thank you. Dr. Qudratullah, now we want to talk about the thyroid. If we can give it, what is the simple form of explaining what's a thyroid glands? What's the difference between having a thyroid disease or issue or could be cancer?
Let me expand on this, that as a surgeon, how we face patients who come to us to see what's wrong with their thyroid. First of all, thyroid is located in front of the air pipe, we call it trachea over here. It takes up the form of butterfly, and in Arabic they call it غدة درقية, and also then غدة فراشة, it's butterfly. It's exactly like that. So, and thyroid, it's a gland. There is multiple level cannot walk and lives off. That's it. So sometimes having also sometimes and this is for the audience. Thyroid disease is basically, let's mention again that when somebody has a lump, and these lumps are sometimes if it's big enough, it's palpated by patient themselves. Sometimes they see it through incidentally. Let's go, you have some ache, neck ache or a problem, they do an ultrasound or on any other images on CT, MRI, and you find that there is something like this. Yeah. We call these incidental findings. So this could be there as incidental findings, but palpated by patient themselves. So, as I mentioned, more than 50% of the population, they have this one. But about 10%, they feel it. And the other categories, as I mentioned, it's not, I don't want to repeat that, it's incidental.
But doctor, if I may interrupt, the lump that you say that they can feel it, is it like it's showing out from the neck, like it's visible, I can see it, I can touch it, is it strong, hard, is it soft?
That's, it depends on the location inside, because it's kind of wrapped around the air pipe. And how big is that? And it's a relative, how big is the neck tissue, fat tissue. So cosmetically sometimes it's obvious.
Okay.
So we can see that. So some of them are benign, some of them are cancerous. But I tell you, only about 5% of thyroid nodules are cancerous. And when we talk about cancer, which I'm going to come back to that, it doesn't mean that's the end of story. Cancer is going to kill us. That's not true, because thyroid cancers, which I say about 5% of these things, and 95% of the others are benign, and could be managed. There are many ways to manage that. I'm going to come to that one. With the nodule, usually we check a couple of things. One is that, what is the level of thyroid stimulating hormone? That's because we have a feedback loop which is between in the brain and gland, and pituitary gland releases something called thyroid stimulating hormone, only thyroid gland itself. And thyroid gland releases hormones which are T3, T4. Many times when we have the lab result on the thyroid, we'll see all this kind of. It means the thyroid produces the hormone, and hormones are there. Whenever the level goes up, it has a negative feedback on the pituitary gland to stop thyroid stimulating hormone to come down. So if it's high, that one goes down. If this is high and this is high, and there is out of control, this is when we face something which is functioning high more.
Yeah.
Or we're going to come back to that. This is kind of a little bit, maybe it's too much or confusing, but it's kind of detailed, a bit more professional side of the story.
But
Let's not
this
get
is-
into that one. I don't
yeah.
want to get the audience confused on this one.
But this is the...
What is it? It's history. We talk to the patient.
Yes.
So
It could be
they
genetic?
Genetical, it has a role, but let's call it familial to be concerned with that one.
Yes.
If you somebody has a history of radiation to the neck area, that could increase the chance of having. So these are bad risks, high risk. And additionally, somebody really had a family history of the thyroid gland. And there are some other diseases which some people, very rarely, they have a package of bad disease and could be a part of it. So this is first thing, history, talking to the patient.
Sure.
So what is the background is important to evaluate and to find out where we put the patient exactly.
Yes.
Second thing is we do a lab test to check for these hormones, TSH, T3, T4, just in summary. And then it comes to story of ultrasound, imaging. The ultrasound, sometimes we do CT when it's needed, even MRI. So,
but these are very common scans patients should go to it, so nothing scary for them.
Every patient with a nodule definitely goes under ultrasound.
Yeah.
But the story is not finished, because after we do ultrasound, there are certain characteristics of the ultrasound finding which tells whether this nodule should be biopsied or not.
Okay.
Because the issue is the tissue. That's what we say. We found, so what puts a nodule under the category to be biopsied? Size of it, if something is bigger than 1 centimeter, if the nodule is irregular in shape, you have vascular. Based on this one, there is a classification we call thyroid, like in breast, which we call birod. And then this will tell you whether we should put this under observation or whether just attack this one with a FNA, which is fine needle aspiration. This means that under ultrasound guidance, we locate the area after cleaning and draping in a clean environment.
Yeah.
Sometimes we use local anesthesia, so the fluid,
Okay.
the aspirate, the content actually. It might be fluid sometimes, it can be some hard tissue. What we're looking for, there are cells. So we send this to laboratory for cytology. The result of this one interpretation is quite interesting.
Yes.
And we have classification, actually 6 ones. Sometimes it's just to say that they cannot give an opinion on this one, most probably because we didn't attack the right place or we don't have enough tissue to look at it. In these cases, we usually repeat the FNA or biopsy. This is how it goes. Second one is, so there are other categories. Sometimes they say, okay, it's a benign thing, sometimes, or definite cancer. So these are a different category. What the problem is that the intermediate one, because it shows some atypical cell. Atypical, it means cell, they don't look normal, but they don't look bad or nasty either. Now that is a difficult. We repeat this or we go for surgery. But on this classification, we call it Bethesda classification, from 4, 5, 6, surgery. Most of the time, surgery.
Doctor, before we go into the surgery, I just wanted to let or inform the viewers who just joined us that the topic today is about management thyroid nodules and talking about the thyroid glands and how can we manage it through surgery. And Dr. Qudratullah is taking us through the process. Doctor, I know some of our viewers now want to know, how do you prepare a patient coming to you with a thyroid issue that requires surgery? So how do you prepare them for this? What steps they need to do? And definitely the most common question will be coming from a patient is the recovery.
We all definitely, we have a very family environment, friendly environment, personally, and definitely my colleagues are like that. We like to really get the patient to the details and answer all the questions. We have to be on the same page, the same boat, because that's what, I mean, we need each other definitely all the way. So it's not me or just the patient, that's for sure. So we explain things, we explain the finding. After we have the pathology, let's say that would need surgery, we explain why, and what we can also, we explain what are the pros and cons of
the
the
surgery.
and what are, of course, alternatives all the time should be provided to the patient, and that's what we have.
Sorry,
but one just
yeah.
I don't want to forget that this needs a team.
Yeah.
It's not a one-man show. It's not a solo thing. We have a good team here. It's an endocrinologist and to some extent definitely surgical oncologist, and also other disciplines that might be needed. Let's say diabetologist, which is endocrinologist. We in Medcare as a team, I work together with Dr. Mahendra, Dr. Hussam, our chief, and our endocrinologist currently is Dr. Abdul Jabbar, available to us, and also our medical oncologist, Dr. Tarek. So at their service anytime. We are on the same boat. We speak things. So we get the patient to that spot. So what happens? Usually, patient come with a plan. Definitely, on the day of surgery, patient is taken, and anesthesia definitely is a big part of this one. Before surgery, one more thing, we have to check the vocal cord, the function, whether the patient is having a normal movement of the vocal cord.
What difference would that make, doctor?
If I tell you what are the indication for surgery, then definitely you understand what I'm talking about. Indication of surgery are when we have definite diagnosis of cancer.
Yeah.
Sometimes surgery is done not for cancer, for cosmetic reasons. So let's somebody has a big cyst.
Okay.
A nodule sometimes is a cyst. It's not just aggregation of cells or adenoma. There are many types of things. So that lump could be a cyst, could be adenoma, could be cancer, or could be a part of inflammatory diseases of the thyroid, which is called autoimmune diseases, like the typical one is called Hashimoto thyroiditis. These all could be there. So indication for surgery are definite diagnosis, compression syndrome when it comes because we have the nerves responsible for our vocal cord, what I'm talking here, low pitch, high pitch. Sometimes patients come with some symptoms. There are definitely 3 questions that we ask in addition to what I mentioned, that whether they have dyspnea, means difficulty in breathing, change of voice. This could be husky voice or hoarseness. These are the compression of the on the what you call it, the recurrent laryngeal nerve. That's what we call it on both sides. It's going posterior behind the it's come from up. They make a loop and they go back and behind the aspect or behind the wall of the thyroid gland, and this is how they reach the muscle for the vocal cord.
And if there is a change, and I mean if one of the questions of those 3 is yes, there is a change of either voice or heart.
This should be documented, because there are complications to each surgery. I'm not talking about a general one, which is like infection or just minor bleeding. The particular to this surgery, when we remove the whole gland, we call it total thyroidectomy, or a part of it, and half of it called hemithyroidectomy. These are the things, either half of it or all of it. Now, the complication of surgery, one of them, there are 3 of them actually, which is major. The most feared one is that if voice is attacked by chance, because we use cautery, burning, or maybe the bad processes like malignancies, there and entrap the thing, and while we're dissecting, maybe it's pulled. So this might result in a change or loss of voice, transient or permanent. Now, post-surgery, some of those changes might be there. Part of it is because of intubation by general anesthesia, or part of it because of surgery. Many of them, these are because of the nerve paralysis. They'll go away. But we need to document that.
Sure.
Some people have it. If we don't document that, so after that we see some of these things are not functioning well, then we know where we're standing. The other this was about the nerve. That's the most feared one. But nowadays, this is avoided also. We have something that's called a nerve stimulator. It's a device which is connected to the body of the patient and also through the tube for anesthesia close to the vocal cord, and also through a device to the skin, and that has a probe. When we touch the nerve, it tells us there is a nerve. So it gets us out of confusion where we see white structures, because nerve is white. If you see something, a fibrotic tissue next to that one, and we cannot differentiate, it tells us that's a nerve. That's why it helps us. I call this GPS of the thyroid gland, GPS. But like the other GPS, you have to know your north, south,
for sure.
east, and west. Otherwise, you might get lost, because these are machines, you cannot rely on them completely. They're just accessory to help us. Surgeries like this, especially, very important to be in good time. Other complications, which I mentioned, there are two more, and then I'm going to finish in the story of this one. Parathyroid gland, jar daraqiyya in Arabic.
Yeah.
So these are the neighbors. These are little things are responsible, these are glands also, responsible for regulating the level of calcium in the body. And actually in the blood, so the calcium level is higher. So how they absorb calcium whenever it is low from the intestine, and if it's needed, it's not enough, they mobilize from the bone. That's why they keep the equilibrium of the calcium inside.
Yeah.
Now, this through the surgery sometimes, because we are cutting, burning, the blood supply of this gland might be compromised. It will lead to hypofunction, which is most of the time is transient. And the other thing is sometimes, without knowing, we might remove one of this one. This could happen sometimes because of the embryological origin of the thyroid, parathyroid. They are together coming. Sometimes these are not separated well, and one of them is entrapped in the capsule. We cannot do anything about this. A certain percentage of this one, after histopathology examination of the final specimen after surgery, they tell us, yeah, we have, let's say, one parathyroid. So patients are given vitamin D and calcium on a regular basis, and post-operative they are checked. One last complication might happen in certain patient. We might have bleeding post-operatively. This needs really close observation after surgery, usually in the recovery room or within the first 24 hours. So we need to take this seriously, because it can be expanding hematoma, bleeding. That's an emergency. But these are not to scare anyone. These are very rare things. Complication happens, but when you know how to fix them, there is no problem. There is no surgery without complication. We explain everything to patient. Patient usually stay. Sometimes same day, we do the surgery in the morning, they leave the hospital at night, or they go next day, definitely, after checking things are fine. If you don't have a question, I have one more thing, is about surgery itself.
Yeah, I'm a little bit mindful about the time. I'm sure the audience would want to know about the recovery after the surgery, what they should do, how long does it take from a recovery of this kind of surgery?
Patient can go back to their work.
And back to normal and back to their function. There's also one more question I want to stress on is after.
Sometimes when you go half of it, sometimes when it's all of it. One more thing is that we study is that, because if we're talking about, let's say, cancer cases, because cancer, some types of thyroid cancer, they travel through the blood. Some of them through the lymph node system, lymphatic system. That's why we study lymphatic system, and if needed, if it's suspicious, during the operation, we remove that one. There are many types of cancer of the thyroid in terms of how they behave. They call it undifferentiated or differentiated. But the good news is the most common thyroid cancer, which is the popular one, is a papillary carcinoma. And which means that it has a good prognosis, almost more than about 95% 10-year survival. It means that you diagnose it, you remove it, patient will be fine. Sometimes after surgery, definitely you need some adjuvant treatment that could be radioimmunoassay. Radioactive iodine treatment, which is a different story. So all in all, patients do well, they go home fine. One more thing is that people are concerned about the cut, how big the surgery cut is. We don't do big cuts because we have the instrument and expertise to do that. So we usually find the best place, which is the normal skin creas, and because they heal well. This is the open surgery. There are other approaches, endoscopic approaches, like through the oral cavity, is called vestibular endoscopic approach, or the axillary. Now there are many studies on this, controversial, the schools, who is better than that one. Cosmetics and need of the patient, these will define and lead us which one is better for the patient. But we don't have so many cases done in these new techniques, and that needs individual tailoring to be done.
Yes.
I guess a small cut to see everything just in front of your eyes and deal with it, it's not a bad idea.
Absolutely. So. And with this point, I would like to thank our audience for attending this very interesting session on thyroid management for the nodules with Dr. Qudratullah Nawraste. He's a consultant and general surgeon and surgical oncologist at Medcare Dubai. Thank you so much for sharing your questions with us. Until we see you next session, take care and stay safe. See you.